getting up there for them.
That's right.
That's what it was. One of the programs we've always approached, or Board of Health have always approached, is supporting grant efforts within health departments, health divisions. I want to talk to you just briefly about a CTG grant that we've had communications from the state that had ended this year. And I want to just talk to you a little bit about how we might proceed in future grant funding when it comes to this CTG grant that came from the feds. In 2012, well, we talked about chronic disease burden in the United States last time. We talked about it in Union County. It was in the document that we gave out on our community health diagnosis. When they started this in the United States, about 7 to 10 deaths occurred caused by chronic conditions, and we've talked about some of those chronic conditions in our programs that we have here, whether it be diabetes, whether it be cancers, other types of chronic conditions. But at the time, 7 out of 10 deaths in the United States were attributed to a chronic condition, and we know that we were spending quite a bit of money on that. So CDC in 2011. Federal government awarded them dollars to the tune of about $103, $104 million. They had some administrative dollars they kept that they could distribute to states and territories around the United States to combat chronic conditions, increase healthy lifestyles, and do other activities within counties. The awardees were really to engage partners, because one of the success stories that they wanted to see was that there were partners brought in. It wasn't just public health, or it wasn't just some territorial jurisdiction working, that we were utilizing other players in the community to improve the health of that community. In 2012, they had such success as far as their distribution that they expanded it to other communities, and those being 500,000 people or less. That's when North Carolina got involved. North Carolina saw an opportunity to apply for this community transformation grant funding to offset some of the health promotion dollars that were being lost by the state government. And so they expanded CTG and opened the bidding process back up in 2012. At that time, what they wanted to do was create, again, healthier communities. And the strategies that they used, as you have it here, is tobacco-free living, active living and healthy eating, clinical and community preventive services to control high blood pressure, high cholesterol. Those were the topics. And they also focused on health promotions and disease prevention. And one of the other big items that they focused on was healthy environments. In other words, walking to schools, sidewalks, bike trails, those types of things that local governments have a hard time funding, and using these federal dollars to do that. Now, some of the community interventions that included with CTG was, again, access to physical activity through physical education instructions in schools, increased access to healthy foods, and we'll talk about that, particularly with the farmers market. They wanted to reach secondhand smoke exposure. North Carolina was very proactive in that, but there was still some work to be done. They also wanted to promote improvements in sidewalks and street lighting, and we talked about that to make it easier for people to walk and ride bikes. For instance, DOT building the bypass from 485 to Marshville was 23 some odd miles. A good opportunity to put a bike lane 23 miles. We've all been in Union County, we've all ridden, give people a place to go. So it was opportunities to partner with those types of institutions to create better paths for those. 20% of all the program funding was directed at programs and policies in the rural and frontier areas. So they held back 20% to go in those most rural areas. Now, I will tell you, Charlotte and Mecklenburg County and Wake County were not eligible for the funding with the state. They had to apply on their own because they exceeded some thresholds that they had in there. So North Carolina. In 2012, North Carolina applied and was awarded over $7 million. Now, that $7 million was over a 5-year period, if I'm not mistaken. The total $7 million was over 5 years. And they divided the state at that point into 10 regions. 10 regions of 10 counties each. Now, Mecklenburg was part of our region, but they couldn't utilize any of the dollars. So it really became a 9-county region for us. Cabarrus Health Alliance actually held the money. They had a different accounting situation, but they held the money for our region. So what did we do with those dollars? We had about $40,000 in actual purchases that came to Union County. That doesn't sound like a lot, but $40,000 we didn't have. I added this slide in based on what you had in the actual information because we had some information about that. But you know, the farmers market, we put together farmers market supplies and promotions. If you notice, there's 50 some odd stainless steel tables at the farmers market, the signage, the promotional materials. We did billboards for them, electronic billboards. I think there was $90,000 spent in the 10-county region on eating local foods. So that was an opportunity for us to do that. We ended up purchasing fitness equipment for the Boys and Girls Clubs. We wanted to do a joint use agreement to measure the obesity and healthy living for those young 300 kids. So we had the opportunity to bring in fitness equipment for the Boys and Girls Clubs just to see if that small population of school kids, if we could make a difference for them. That money paid for travel. That money paid for billboards, as we talked about, materials. We had some posters, pamphlets, those types of materials, and then collaborative efforts, and that comes in those joint use agreements. It gave us opportunities to open doors with other players. As I said before, there was about $98,000 in regional communication contracts, and that came up to about $9,800 per county if you average it on 10. We got a little bit more. So for a total for Union County, we utilized about $50,000 of that money. And that was money that came through the state, through the federal grant that we didn't have, that we did not have prior to. Now, we talked about this, the farmers market upgrades with the office equipment, the advertising and promotion, the tobacco-free signage at SBCC. SBCC went tobacco-free. We helped them buy their signage on that campus. And we also had the opportunity to do a farm stand at the Division of Public Health, and we worked on that, and that was to buy permit and licensing fees, and that's just an extension of the farmers market here. So it was just trying to make small steps along the way. We had this money for approximately 3 years. We don't really have any of the results tabulated yet as far as any conditions. We talked about chronic conditions and chronic diseases, and you know how long it takes for those to change over time, behaviors and habits. So that's still being tabulated. So we're in 3 years of a 5-year grant that the federal government pulled back. And they decided they did not want to fund that program anymore. They had rerouted some of that funding. We don't know why, we just know it disappeared. It had threatened to disappear 2 years ago. We held out for another year and a half. And again, it's very difficult to measure the chronic conditions. What I'm here today just talking to you about briefly is that these opportunities don't come along that often, particularly when it comes to the federal government providing such large, substantial amounts of money to local governments without application on our part. I mean, the state had a chance to apply. We got to draw down those dollars. For us, it's a great opportunity to communicate with our federal legislators and ask them to consider in future budgets these type of expansion projects that we know work. We don't currently have the tabulations here, to offset some local dollars that we could possibly, that we just don't have. So I guess I come to the board tonight and just ask for at least somewhat of a discussion or maybe an endorsement on allowing us to talk to those federal funders and to those legislators and say, if the opportunity arises, please revisit some of these health promotion funding opportunities that you've done in the past, if at all possible. What we don't get, and I think anyone would agree, most of the applications we have to do on our own. It's very rare that you get the opportunity to pull down federal dollars that they've done the work for you. We do have reporting that we have to do, but at the same time we have to measure our impact. But at the same time, that money is currently gone. And I think we have made a difference with it. We won't know for a while, but we've had the opportunity to at least buy things that we know we needed, not things that we would pack away and store. Any comments? I know that was very quick. Our CTG experts are on vacation this week, but it's there anything in particular about that program or about any thoughts about us, continuing to work with our federal partners, federal legislators, and as we've done in the past, and ask them for additional funding for public health activity?
Mr. Tarter, it sounds like maybe I've made an erroneous assumption. Just for clarification, you were talking about, I think, years of the 5-year grant, years 1, 2, and 3 funding. They pulled back in year 4, if I recall.
They funded through year 3, which we're in now.
Okay. And it looks like with the initiatives that you funded, that we don't have anything left hanging in the balance, or do you look at that each year as funds available for an open and closed project and not a perpetual project that they do pull?
We do. We look at it as an opportunity to fund what we know is sitting on the table at that moment. But it all relates back to their goals of those long-range chronic conditions. We want to decrease, diabetes in this community by 10% in the next 5 years. So we have to tie it back, like our action plans, and tie it back to that particular goal. And so if we think about healthy eating, what's a small thing we can do here? What's a small thing with Boys and Girls Clubs that we can do with them? So it's trying to get those small pockets with that amount of money you have at that time, because you're not guaranteed that next year's funding, but you want to make the most impact. But there are measurable goals at the end. We just didn't get to that point. Which I think is going to be very difficult for them to measure their 5-year projections as well. And potentially could be on the federal level seen as a failure if you can't get to that point, and then future funding doesn't come down.
Well, I certainly think all of us here will endorse the efforts to secure additional funding.
Okay.
All right, moving on to item number 6.
All right. Last on our agenda was obviously, we talked about fees last time, bringing fees occasionally, and we are still looking at our overall fee structure. These 4 fees that you have here, obviously, the first is an ultrasound code in our maternity clinic. The 98,960, which is 30 minutes of counseling, and both the 15 minutes of counseling by phone. That is the Wise Woman Project. If you ask why is a 15-minute counseling different than a 30-minute counseling, why is it more expensive for 15 versus 30 or reimbursement, there are other services that are bundled into a visit when that person comes, and that's what they allow for. So there are additional services that will be provided on site at that time, lab work, et cetera, in conjunction with that. The last one is a vaccine, where it's our diphtheria and tetanus. The state had a vaccine for children program for years. They have since stopped that program, and you have to meet certain eligibility criteria now because they do not pay for vaccines across the board for children anymore. So there are various vaccines that we have to order privately to keep on stock when someone comes in to be able to administer. And those are those 4 fees that you have here.
Phil, real quick.
Yes, sir.
Are these fees just like the max allowed by the state, or is there some method behind the fee?
There is. These fees are actually, we have a policy, we set them based on Medicaid rate, surrounding physicians' offices, maximum allowable by our insurance carriers, and we combine those to determine what that fee is going to be.
And you're obviously not recouping 100%. Are you recouping 20%, 50%?
For these, we're recouping the entire cost. We're recouping the entire cost of the purchase of the vaccine plus the administrative fee. I think at last guessed on, it's different for every fee. We recoup anywhere from 50 to 70%, just depends on that. Some fees we do collect 100%. But it just depends if they touch an interpreter or if they do some other incidental costs that we have it calculated for.
Mr. Chairman, we adopt the fees as presented.
All in favor? Aye. Opposed? None? Thank you.
I'm sorry. I need to ask for clarification because I think I heard one thing, but I see something else. You indicated that on the 30 minutes of counseling in person was more expensive because they
allow less reimbursement for that 15-minute visit.
That's why the 15 minutes on phone is more expensive?
That is
because of the
correct.
reimbursement rate?
It's a reimbursement
okay.
rate.
All right. Sorry.
And they assume that you're
Didn't quite
gonna,
get it.
they'll assume that you'll have lab work and other, we
Okay.
do have other incidentals that come along with it.
All right. Sorry.
Thank you.
Anything else?
That's it.
All right, appreciate it. That it?
You have 30 minutes.
All right. We'll go ahead and adjourn this meeting. All in favor? Opposed, none.